Morning, everyone. Thank you very much. Please bear with me. I struggle. This is a new phenomena I have, that I have to wear my glasses just to keep an eye on my notes here, which is a priority. And I can get a bit dizzy when I'm looking between the crowd and the overhead projector. So if I suddenly start to wobble, please tell me to stop. Okay, so hypersensitivity or infusion-related reactions to chemotherapy or our newer drugs, the systemic anti-cancer therapies, feels like it's increasing over the last 10 years. But this is probably more to do with the explosion of new drugs that we've had come into our normal practice. Hypersensitivity reactions are adverse events resembling an allergy, and anaphylaxis really means without protection and immune protection, and is a serious allergic reaction which can have a rapid onset. The reactions can be anaphylactic or anaphylactoid, and I'm going to try and explain a little bit, a very brief simple explanation. But I suppose the important thing to remember is, regardless of what's caused it, their clinical presentation tends to be the same symptoms, and therefore prompt recognition, accurate assessment and prompt management to avoid seriousness, adverse events or even fatality is what's of the importance to us as nurses working in our units and treating these patients. So, let me just do one, two. Oh. Anaphylactic reaction. So we have our mast cells, and the drug is introduced either orally or, in most cases, injected into our body. It will be on the surface of our mast cells, we have the immunoglobulin E antibodies. Now, for an anaphylactic reaction, in a lot of cases, it will be that the patient has had prior exposure to the substance. So it could be a food substance, it could be the actual drug. But sometimes there is a cross reaction. So suddenly what happens is the drug binds to the IgE antibodies, which in turn causes the mast cells to release these mediators. As opposed to an anaphylactoid reaction, what happens here is when the drug is taken in, it triggers an enzymatic cascade, which is called the complement system. And this in turn triggers the mast cell to release all of these mediator factors as well. And when these mediators are released, histamine, heparin, platelet activating factor, prostaglandins, leukotrienes, kinines, tryptase, they can cause bronchoconstriction, vasodilation and increased permeability that are responsible for the clinical features of anaphylaxis. What has to be remembered is this is normal immunological and inflammatory responses. So when we inject these drugs, we're doing an overstimulation of the immune system, and it causes this severe reaction. So what are the clinical features? I was going to ask you all to start shouting them out, but I've just gone ahead. So the reactions, as I say, can vary from mild to life-threatening, and they can occur in a few minutes or a couple of hours or a few hours later. So if we look at something like Herceptin, trastuzumab, we've administered the first infusion, and whilst it's an hour and a half, when it used to be the straightforward IV infusion, we would see reactions maybe that would occur an hour into the infusion. But one of the things we had to do was observe patients for a few hours afterwards. And in a very small number of cases, we did actually see patients who developed severe reactions post in this particular treatment. So for patients presenting, they can have mild symptoms, which will be the itching. I think some of us, as I just say, when we're walking around our departments and we look as if we're doing other things, actually what we're always constantly doing is, one of the things is watching out, is a patient reacting? And I think one of the things I'd always class, I see the patient suddenly scratching their hands, rubbing their knees. That's a great one. And you think, yep, they're having a reaction to something. Where facial flushing, the feeling of warmth, very classic. There is a lady up there at the back wearing a red jumper, and I think one of the things is just warning our patients, sorry to point you out, but I think facial flushing, it's really at the point that we start these treatments, it's reminding relatives if they're with them, or as nurses watching out, has the patient developed suddenly severe redness? That can be a sign that something's having a reaction. Less, and they probably become more individual to various drugs, is symptoms of nausea, lumbar back pain. And as we work with our patients and give certain drugs more and more often, you begin to become familiar with which drugs. So Paclitaxel, I would say, is quite classic for causing lower back pain. Patients will quite often complain of that. Nausea, we can be tempted to think that nausea could be a problem as a side effect of the chemotherapy, but actually it can be one of the symptoms of anaphylaxis. As the anaphylaxis or the hypersensitivity reaction progresses, it can be, patients can develop more severe symptoms. So we can have things like coughing, wheezing, sweating. Patients go very pale, grey, clammy. Patients can start to get irritable and have a feeling of impending doom. And actually, I have seen loose bowel motions. Don't see it that often, but I have had one patient who we had, and it went down further, where they actually had uncontrolled vomiting. And once they stopped the vomiting, they went into uncontrolled bowel motions and ended up going to the toilet several times. At the point that the reaction becomes severe, they can have stridor, difficulty breathing, laryngeal spasm, and then start to go into shock and respiratory cardiac arrest. I suppose one of my first questions to think is, in our day units or in our outpatient departments, our ward areas where we're treating patients, what are the things that we're going to start thinking about to prepare us or to do the best we can for our patients? What sort of patient assessment are we going to do? No, sorry, just prior to us even treating, I should say, actually treating the patient with the drug, what patient assessment would we do? No, before they've had the reaction. We haven't have they got any allergies? Yeah, that's it. So prior to us even treating the patient and giving any drug, prior to each time we treat a patient, and not to assume that every time we give a drug, and if the patient has had it 20 times beforehand, that they're not going to react this time, and I will explain in a little bit. But I think it's actually, has the patient got any known allergies? We always have to ask that question. I think read the notes and see what we can glean from there. It's also useful to actually ask the patient if they have had prior treatments, have they had any reactions? They will describe it all very vague. Patients may describe it as funny turns, and you'll have to explore that a bit more with them. But some patients may actually say, yes, I did notice I had some itching during the last infusion. It doesn't mean you won't go ahead with today's treatment. It just means that you'll have a bit more caution as you go into treating them. Working in our day units or on our wards, or where we might treat patients with oral drugs in our outpatients, I think we all need to think about these number of reactions. We're seeing more and more of them. So it's actually making sure that our work environment is prepared. So are our staff trained? Have they kept up to date with their STAT-MAN training for anaphylaxis? But I also think it's about thinking about the environment we work in. So what happens? What's our day unit like if a patient suddenly collapses? We won't have an action plan for every possible scenario, but it's actually thinking through some bits of processes. Have we got the crash trolley or access to it? Do we have adrenaline? Where is it stored? Do we have an anaphylaxis kit? Some areas will have anaphylaxis kits that contain everything, that you can just go and grab the box and you've got everything that you need. Do we have screens so that if our patients become suddenly ill? What about the manual handling of our patients? So if a patient suddenly deteriorates, how best are we going to manage? As I say, we won't have thought of every scenario, but it's having some ideas of how we're going to get patients to the floor, up onto a bed, whatever we need to do. So the common drugs, on a personal level, but you can all disagree with me, I've moved carboplatin sort of up to the top. That's probably because I am predominantly oncology, but I think as we treat patients, people are living longer. We're treating patients with cancer for longer. We are using carboplatin more and more. Now, if carboplatin is given first line, so that's when it's given cycles 1 to 6, generally it's well tolerated. It might be that it's given alongside a taxane, at which point they're getting a hefty pre-medication with it. So we're not going to get a true reflection of, is a patient going to have a reaction to it? But what's becoming more common, especially in the world of ovarian cancer, is that we're now using it as second line treatment. So basically patients have an interval of at least 6 months from finishing cycle 6 and then maybe resuming carboplatin again. And what case histories in the literature are showing is that as we give each subsequent cycle, the risk of developing anaphylaxis to carboplatin increases substantially. And even to the point now that in our day unit we've managed to give carboplatin as a 4th line treatment. So that means the patients managed to go through and have it as a, they've had at least 6 month intervals between every 6 cycles. Thankfully, they've done well. One of our oncologists is, because she has had patients who've had several reactions or anaphylaxis to carboplatin, she now does pre-medication before giving second line carboplatin. So once we go to cycle 7 onwards, she's looking at giving pre-medication automatically. The evidence actually doesn't show that to be necessarily of any value. I suppose on a pragmatic level, we do find it helpful. The other thing that can be used for patients who develop sensitivities to carboplatin is a desensitization program. And the literature varies. Some it involves starting the infusion slower, but actually to do full-blown desensitization, it can be a 12-step process. So you're starting at very small doses and gradually increasing over 12 steps and completing that whole infusion. And that can work with carboplatin. What you've got to do is actually evaluate the risk of serious adverse effect to the patient plus over the benefit of having that particular treatment. In some cases, I've seen carboplatin has been swapped to cisplatin, and the literature would say it's of limited value. Sometimes it works, sometimes it doesn't. Oxaliplatin would be the next one. 1% of patients will have reactions, and they can be life-threatening. Has anybody ever had a serious anaphylaxis to oxaliplatin? No, okay, we have. But what's important or what's unusual about oxaliplatin is it doesn't occur with the first or the second. It can actually occur as you go further on in the treatment. So historically, if we're giving oxaliplatin as part of a mod de Grommet regimen, where you're giving it every 2 weeks, it's always been known it would happen at the 7th, 8th cycle. But now that we've swapped to giving oxaliplatin with capecitabine, so you're giving it as a 3-weekly cycle, a higher dose, but every 3 weeks. The case histories are saying that these reactions can occur at around the 6th cycle. And what they're also suggesting is that pre-medication is not really reliable. We will automatically do it, but there's no evidence to say that it's of any good. There is a case history on where they have tried desensitization, and it's that 12-step approach where they've looked at giving oxaliplatin to somebody who reacted post with cycle 2, and it was very much in the adjuvant setting. At the last minute, I threw cisplatin in here. I've been giving cisplatin for 30 years, and I never had anybody react to it. I never saw a reaction, and then 3 weeks ago we had a reaction in our day unit to cisplatin. It was, on the grand scheme of things, was a mild reaction. They had a full urticarial rash all over their body, and it was at the point that they finished the infusion. So it wasn't during, but it was at the point that they had finished and they were into post-hydration. The new drugs, all of our monoclonal antibodies, they will all come, trastuzumab, rituximab, they all come with some degree of infusion reaction. And all these new drugs, and I think this is what's making chemotherapy nursing exciting, is that we don't just have all of our classic drugs and all of the classic side effects to learn. As you work in the area for a long time, we're now moving into the new drugs, and we have a whole wealth of new side effects and new reactions to learn. And so all of these drugs will come with their own pre-medication that you have to look at on a one-by-one basis. I know, Jane, in haematology, you've got a new drug that's quite complex in its own scheme on what pre-med you give, and if the patient reacts, what you do. But to try and prevent these reactions, there's any combination of pre-medication, including steroids, antihistamines, and at what infusion rates we start and gradually escalate. So we have quite a lot of drugs where we may start slower for cycle 1 and then gradually increase. So liposomal doxorubicin would be a classic, where you give it over 90 minutes for first infusion. Subsequent cycles you will do much quicker. Then we go to asparaginase, really giving IV. There is talk about, once again, it's a bit like carboplatin. If you leave an interval between treatments, the risk of reaction increases. Docetaxel, Paclitaxel, if we don't give pre-medication, then 40 to 50% of patients will have a reaction to these drugs. Interestingly, there's an article come out, we're currently reviewing it and debating, but where we give weekly Paclitaxel infusions, there is talk about us not giving a pre-med with that drug. To me, at the moment, my reaction, it feels like getting in a car and driving without a seatbelt. But I think it's something that we need to give. Even if we could swap from IV pre-medication to oral, from our day unit point of view, pragmatic, it would make, it would help enormously, especially as we have had a huge increase in the amount of weekly Taxels that we administer. And then the newer targeted therapies, so such as what Simon has talked about, pembrolizumab and nivolumab, they're just starting to come out into our standard day unit areas now. Very exciting, but as the early phase team like to keep telling me, at least 2% of patients will have an anaphylactic reaction. And as we have now got near treating 100 episodes, I am waiting for the anaphylaxis reaction. But it is just watching this space. And it's also not forgetting all of our old drugs, our old classic chemotherapy. So whilst we focus on our new drugs, we've also got to remember our old drugs. So our drugs like bleomycin, we always give hydrocortisone with that. Adriamycin, when we treat patients through a peripheral cannula, it's remembering they can get anthracycline flare. Etoposide, this has surprised me. It keeps coming up in the literature as people potentially having allergic reactions to it. Touch wood, I haven't seen anybody yet, but I dare say when we go back, something will happen. One of you will email me, something like that. And likewise with cyclophosphamide. So it's remembering this can happen. So what do we do? Management. So as we're going around, it's If they're on an infusion, stop the infusion. Then instigate our ABCDE, so looking at doing our assessment. Now I think as nurses, and certainly as more experienced nurses, we're probably multitasking and doing things at various levels and going through the process in various formats. But it is checking the patient's airway, checking breathing, listening to the breathing. Is there any, can we hear wheezing, stridor? Looking at circulation. Are they becoming cyanosed? Checking the pulse. Are they tachycardic? Is it weak? Is it strong? How alert? Are they conscious, unconscious, or are they losing consciousness? And then have they developed a rash? It's then the next thing, depending on the severity. So if it's mild, let's look at what are we going to do. So what do you think we do next? Don't ignore my slides. So I'm walking about the department, and I'm just actually going through the day unit, and I notice Mary in the corner, and I see her doing that with her hands. What am I going to do? Stop the infusion. What else am I going to do? What's the next step? Yeah. Ask the patient how they are and start going through your ABCD. In the background, start making colleagues alert, or one colleague, that, you know, this patient is having a reaction, is poorly. I think have a look and see what the drug is. By the time I'm starting to see it's carboplatin, I don't know what cycle number. I've only just walked through the department. It's not my day out on the floor. I've just copped this. So I'm going to assume that she could be quite, you know, this is her 9th, 10th cycle of carboplatin. I've summoned, or I've alerted one colleague. What am I going to do then? I've stopped the infusion. I'm assessing. The patient is feeling poorly. She's very frightened. Her chest is getting tight. What are we going to do next? Sorry? Yeah, check, does the patient need oxygen? So one of the things, if we've got time, check what their oxygen sats is doing. If their oxygen sats are normal, we don't need to have oxygen, but we need to have it ready to give. But if their oxygen sats are dropping, then we would look at giving oxygen. The next thing, I think if the patient starts to stable out, so they're okay, I suppose the big question is, what do we do next? Get them on a bed, yeah, if you have a bed. Yeah. Yeah. What else? Make sure we've got IV access. So a lot of our patients will. So make sure that we've got saline going through the other arm.
I'd be slightly concerned by now as a patient, just for the knowledge that I might have a biphasic reaction. And I'd quite like you to give me some drugs.
Okay, so what we would do, so according to the Resus Council, what we would need to do is look at, is the patient, are we mild to moderate in our severity, or are we going severe? If we're heading to severe, we should go straight in with the adrenaline epinephrine. So we're looking at a 1 in 1,000 per ml solution, and we would give 0.5 mils into the anterior lateral aspect of the thigh. You do it through close. So it's always, you need to go back and check with your own hospitals as to what pens, injector pens you have available. But it may be that if it comes as a mil, it's always remembering that you've got to eject 0.5 of a mil before you give it to the patient. And it's to rub the area for several minutes afterwards. We may look at giving an antihistamine, chlorpheniramine, 10 to 20 milligrams IV as a slow IV infusion. And then we may look at steroids. Now, a recent Cochrane review doesn't have any evidence about the effectiveness of steroids, but it has demonstrated that in most cases patients are given some degree, and it's hydrocortisone 200 milligrams IV is what is recommended by the Rhesus Council UK. When it comes to your adrenaline, check with your local policies, but the first dose in certain places will be covered by a patient group directive. So as long as you've had your training and are able to give it under a patient group directive, you can give that 0.5 mils. The rest of it then needs to be checked with the doctor and prescribed. And then bronchodilators if required. When it comes to the patient, always reassure the patient, always somebody, and I think that becomes automatic, that one of us would actually be there reassuring the patient and their family and explaining what's going on. And after the event, it's always documenting what has happened, but it's also remembering to complete a yellow card. We don't quite do the yellow cards, I think, as often as we should do, but especially with the new drugs coming out, it's needing to remember to do that. And I'm running out of time. So that's the algorithm from the Rhesus Council UK, what to give. And I think the things that going forward for the future, the biggest thing we have is when to re-challenge, and there's a lot of ambiguity about it, and when to do desensitization. And I believe nurses have a great role to play in working with our colleagues, and I certainly, another idea I said for Werner, if she needs anybody doing ideas for masters or PhD, is looking at anaphylaxis and hypersensitivity reactions and coming up with protocols or guidelines as to when we will re-challenge and do desensitization programs. And I'm going to stop there.